All right, everyone, welcome. Dr. Brian Hawley here. It is Wednesday afternoon, 12 o'clock Central Time. A lot of you are joining us on this. This is a huge enrollment webinar, which my wife hit it on the head. She said, let's do one on posture because she sees a lot of that with her massage clients and her other massage therapists that she has in her studio with her, and they wanted one on posture. So here's what we're doing. We're doing one on posture and some of the biomechanic attributes that go along with it. So a lot of you guys, let me see here the next slide. In case you haven't been on my webinars here, this is kind of the easiest way I've found to get around to people is a webinar versus a live seminar. You don't have to travel, hotel expenses, you don't have to do any of that. This is nice, quick, and easy. So how this works is basically questions. We have over 100, I think it was over 150 registered for this. We have over 30 or 40 already live on this thing. I try to keep them just about an hour so we can get in and out because let's face it, that we're all adults, we're busy, and you don't be staring at a computer screen, and Lord knows you don't be listening to me for more than an hour. So we'll try to keep it in and out. So with that in mind, questions, let's hold questions until at the very end. And what I normally do is just the email I'll be hanging around at is info@clublmt.com. Shoot me an email. I answer these guys, or I answer these emails all the time. I have no problem if you don't have a question today. Email me later in the week or next week. We're all on the same team. My goal is to help. And if I don't know the answer, I'll be upfront and honest, and I'll probably pull my wife or another massage therapist in, or let's face it, our database with other companies that I am their advisor for, table manufacturer companies. I have access to over 60,000 massage therapists and 100,000 chiropractors nationwide. So if I don't know the answer, I'm sure I can find someone that does, okay? So go ahead and don't feel bashful about emailing. I don't mind at all. Notes, I was telling the gang a little bit earlier that after this, it's our lunchtime here in Southern Kentucky. So once I get done with this, we're going to go grab a quick bite to eat, and then I will come back and get things converted, uploaded, and hopefully all that goes well. The internet gods will allow this to happen today, and if it does, I'll get the notes and recordings along with a mini test out to everybody this early afternoon. So that'll be cool, so you guys can watch it later tonight or rewatch it again over the weekend. Certificates and tests, I will also send a short mini quiz. I shouldn't call it a test because it's just basically an attendance quiz to make sure you're actually here and you actually watched the videos or listened to me talk and stuff. Just go ahead and fill out the answers, highlight the answers, or even just email it back. Just an email back with the answers. Number one is A, number two is B, whatever the answers are. And make sure you put how you want your name and credentials to appear on the certificate. And then give us a few days. My staff normally does all the certificates and answers a lot of the questions. They'll get them out to you within 2-3 days, okay? A little disclaimer here. I am not telling you what to do. I am not preaching to you that you should do this because laws are different in every state. It just seems like they change all the time, to be honest with you. So what I am doing here is just sharing what I have done in my clinics for over 20 years and my wife, Jody, massage therapist, what she does in her massage therapists that are with her in her studio, what they do and what we found that works and that has helped us and the clients, okay? Now, just a little bit about me. My background has been in healthcare since the 80s. I'm dating myself, I know. Went to med school, then went to chiropractic school. Been on the road speaking, spoke at many college homecomings from audiences of 5 to a little over 5,000 I've spoken to. And I'm the national director of a couple massage table manufacturing companies. I advise them clinically, and I also answer questions for them. And a couple of chiropractic product companies. I'm their advisor. So we have been having fun doing that as well as having our practice. So little note here, some of you guys that are just joining us, and this is on a recording, at the end of this month, August, I am going to be officially retired from seeing patients. I'm going to be turning my practice over to a young doc that's been shadowing me and been working with me for a while. And I'm going to be doing more webinars, live seminars. I'm putting together a medical massage certification course. I am also putting together an evidence-based or outcomes assessment massage courses. I'm going to be doing that and just a lot more stuff that we're going to be doing. I'm going to be working on a podcast and Pinterest where you can guys go on all the time and get updates and get slides. Another gentleman's going to be wanting to team up with me to help market, because let's face it, we got to get the word out. We could be the best therapists, the best doctors, best business people, but unless we have clients, unless we have a customer, it doesn't mean a thing. So we're going to be working on marketing things to help everyone out. So just a lot of stuff on the horizon. I'm not going to retire and go to a rocket chair and sit on a lake someplace, even though that would be nice. I won't do that. So, but anyways, without further ado, let's go ahead and get started here. We have a lot that I want to cover. What does posture have to do with anything? You know, I was looking for a posture slide. I Googled it, and this was one of the things that came up. And, you know, if you really think of it, how much has modern man really evolved, right? We always come full circle. This one here actually depicts it. You know, we go from Anna back in the Stone Age all the way up to the modern computer guy with the posture. It really hasn't changed much over the years. We thought we were doing good, but now with the advent of technology, I am seeing more kids coming into my clinics with things such as text neck, cervical arthrosis with the facet joints, the iliovertebral joints. I'm seeing the kids come in, whereas I used to only see adults in their 30s, 40s, and 50s have this. Now I'm seeing kids. So our posture is really horrible, and it's getting worse as time goes on. Some of the basic postures that we're going to see, you know, the red one's the ideal, the pink, whatever color your monitor's showing, the second one there. And it varies. For a hyperlordosis, lordosis here in the lumbar, hyperlordosis, which is an anterior head carriage. You have a sway back or hyperkyphosis, okay, combination. You also have flat back Pottinger syndrome. I mean, the pelvic gets nutated. I mean, there's just a ton of things that can go on. But one of the common traits with all of these, said the normal, is an anterior head carriage. It's all anterior of the gravity line, if you notice. So the body follows where the head goes. So when we're looking at clients or dealing with clients, we definitely want to pay special attention to anterior head carriage, okay? Now, posture, what does it got to do with health? You know, why is it so important? Let's talk about it a little bit, how it relates to things, about the nerve supplies. And then I got a case that I want to go over with you. There was an actual case that went into my wife's clinic, and I'm going to share a little bit about what her scenario was and kind of the treatment plan that was done with her. You know, again, I just wanted to tell you, text neck syndrome, this is really becoming paramount now, and we're just starting to realize this. It used to be, if you guys remember, now I'm dating some of you guys, it used to be that when we had the cords with the office phones, the people would have their head tilted to the left or to the right the whole time and held their phone on the shoulder. And that was causing cervical and upper back problems and plexus entrapment syndromes. That was causing a lot of those. You know, we got wise to the fact that we started putting guards or spacers on the phone. Then we started getting the cordless. Then we started getting the headphone sets. You know, now we're into texting. And is it really bad? You know, I mean, we have a picture here that shows the right way and wrong way. I'm going to answer no and yes. The picture here, is this really wrong to do? I'm going to say no for the short-term answer, and here's what I mean by that. It doesn't hurt us. I mean, we're designed to have motion, kinetic motion. So if we needed to look down for something and send a quick, I don't know, or I'm driving, thank you, I'm on my way home, bye. Is that going to hurt us? No, not in my professional opinion. It's not going to hurt us. The problem is when we stay looking in that position for an extended period of time through multiple times throughout the day. That is when the problems start occurring. And if you guys know what I'm talking about, it doesn't have to be just texting. How many times are you on Facebook just looking at the images, looking down? I mean, yeah, the cervical thoracic pain, that junction right there, is going to take a lot of strain and stress. Eventually, you'll start getting arthritic conditions developing in the joint, then you'll start getting numbing, tingling, headaches. A whole plethora of things can start manifesting after a while with this. So just keep in mind, this is something that you even, if you want, download it, laminate it, print it out and laminate it, and put in your consultation room or put in the lobby for people to hear or read about it. Another thing you can do is write a blog or write a blog about texting, the perils of texting, and then about posture. Any of my stuff that you have on my slide here, if you can use it and go for the blog, go right ahead, guys. It's all about building your practice and making the public aware. Again, if you're not getting your client's email, if I could slap you on your hand, I would. Make sure whenever they come in, you always get their email, and then, my gosh, send them a weekly or a bi-monthly e-newsletter with just tips of the day. Tell them all the things that they really don't know or they should know. And then every now and then, if you have a special, announce that too. But you'll provide a huge following if you start doing that. So share some of this stuff that we're saying here. Here's a case study I promised you. Anna, in her early 30s, works as a data entry person, comes in to see you for a massage evaluation. Said, you heard you're pretty good. You got the Midas touch. You can help her. So you sit her down, you kind of talk to her, you kind of get a little history. And, well, Anna, what's going on with you today? And she says, well, I get 3 to 4 headaches a week. At times my left hand will go numb. My thumb and the first couple fingers, they'll go numb, especially toward the end of the workday. Why would that be a clue? You have to think about that. Why would it be a clue at the end of the workday versus when she first wakes up? Okay. Well, first of all, I can tell you, if she first wakes up, if she doesn't go to bed with it, then she's probably sleeping with 2 pillows instead of 1. Her bed is probably old. She probably needs a new pillow. She's probably stressing before she goes to bed. Probably got teeth grinding, got some TMJ stuff going on. There's a number of things going on. Toward the end of the workday, it's probably posture and biomechanics, probably stress, okay? Repetitive stress syndrome, RSS, okay? Now, she also has pain in the cervical thoracic junction. A lot of the women, a lot of the guys do, right at the base of the neck, the upper back, between the shoulder blades. You ask her if she's on meds, anti-inflams, trigger point injections, anything like that. She denies it. She says no, just occasional over-the-counter Advil or something like that, or Tylenol. Now, she has been getting some bad heartburn lately, and it's not because she just ate Italian food with pepperoni. She doesn't know why. The last couple of weeks she's been getting heartburn. And then now she can't be, she's having trouble sleeping. She finds that she keeps waking herself up snoring. Okay. Are all those clues to something might be going on with posture? Yeah, it really is. Now, thinking that a massage, she's thinking just come in, have a massage, go home and have a glass of red wine and chill out with a bath of Calgon is going to help her. Now, you'd be surprised at the number of massage therapists or even chiropractors or other just physical medicine people that would just have her do that. They'd come in, we'll try a 30-minute session or a 60-minute session, and we'll see you next month. See how that does. There's a lot of them that do that, and they would treat Anna the same way that they would a bodybuilder, a truck driver, a teacher, or anybody else that had even opposite symptoms. So what I want to get through to you guys is what we do is we look at the whole profile. Our massage therapists don't diagnose, but they do an assessment. Obviously you guys already got some ideas of what could be going on. You know that a Swedish massage probably ain't going to hurt her, or it probably isn't going to help solve her symptoms. Is it going to make her feel better for a little bit? Yeah. And I'm not knocking Swedish. I'm not, because we do it, but I'm just saying there's certain types at appropriate times that are more conducive to helping the client. So so think about what you would do and kind of what you think she has. We're going to go over a few things, and we're going to come back to Anna, and I'm going to tell you what actually we found out with her, because she was a client. Her name wasn't Anna, but and that's not her picture. But I'll go over that with her in a little bit. Let's look a little bit about outcome-based massage therapy, or OBMT. What is it and how it works? The biggest difference a client will see is the intake process. You're going to be doing a history. You're going to be doing a good SOAP, a good subjective. Then you're going to do a good objective. And you can't take pain, for instance. It's hard to make that subjective or objective because it's more of a subjective, because my pain could be different than your pain, could be different than others' pain. So one of the things that we definitely try to objectify whenever they come in is we do a posture analysis. We look at high shoulder, left tilt, left head rotation, pelvic tilt, all these different things, and we make note of it. We also do a range of motion, have them bend, touch their toes, have them bend backwards, stand, go left and right, rotate the head. And we mark any restrictions or the 3 Gs, a grunt, a groan, or a grimace. We mark those as they're doing those. If they have pelvic problems, we have them do a little gait, walk up and down the hallway, 10, 20 feet, and we'll watch their feet through the gait cycle. So this is more of a OBMT type setup here. So a client will present with XYZ subjective complaints like Anna had. The therapist, you are going to determine what's causing XYZ. Now, you're not diagnosing, but you're trying to find out what's causing it, okay? It's obviously with Anna, not just a rough day at the office. There's underlying things that's causing this, so we got to dig a little deeper. So by using range of motion and some other, posture, maybe some ortho tests, some basic things, we can get a baseline of where Anna is at. Then what we're going to do is we're going to design a specific treatment plan for Anna based off of her symptoms, her posture type, her body, and her work habits. Now, at the end of the sessions, it could be 2, it could be 20. I don't know. Everyone's different. At the end of the sessions, the therapist will retest the client using the same test and compare the pre and post treatment results. That would be outcome-based massage therapy. Why is that important, in my opinion, as a clinician? I'm going to say a research person, I weigh my practice, and my wife's followed that suit very heavily, that we just don't go in and do a general massage, even deep tissue, without knowing what the client came in with and doing a pre and post assessment. And the pre and post assessment doesn't always go on, well, Mary, how did you feel? Do you feel like this helped you? Oh, yes. Well, that's subjective. Let's get some proof. Proof is in the pudding. So we'll do a range of motion, we'll do a little exam, and we do some things. It's not diagnosing. It's just doing evaluation so you can monitor how your treatment was handled, and if it also helps you decide if Mary's going to need 1 more, 2 more, or 20 more treatments, how often she's going to need them. So I'm a big proponent of OBMT. And as I said, I'm going to be designing some courses based specifically off this because I think it's that important. So tools, just some things. You can buy some grid charts. You can go on Google and you can do a posture analysis grid chart. I mean, they're not expensive. You can have the client go up against the wall and take a picture of them against the wall. And you look at high shoulders, high head. You can see this one here she's deviating to the right. I mean, it's almost the gravity line's going right, almost hitting her orbital socket. She's shifted over to the right side. Okay. You can also just go to a Hobby Lobby store and just get grid paper, put on the back of a door, put on a wall, and I apologize, the picture's a little blurry, and just take a photograph with your phone if you want. What we do, a lot of them, and I'm not a salesperson for this, I'm just sharing what we do, and I do know the owner of it, and that's what attracted me to it, is we do a posture analysis. We have it. It's a app that you can get at Apple or the App Store. You download it on your phone or your iPad, and you take a picture, and it underlays the grid right behind the client. So you don't have to have a grid on the wall. Then you can put some dots. It'll ask you to put dots on certain landmarks, and then you hit calculate, and then it calculates the amount of forward head posture, how many degrees the patient has. It'll calculate how many extra pounds of pressure that forward head posture is causing on the shoulders and upper back. And it's like a 2-page report this prints out. Now, the cool thing is, if you do, for a marketing thing, if you do a screening or you're at a health fair, you can set up a white sheet and have standing up against the backdrop and have people stand there, and you're taking pictures and you're showing them this. People are going to flock to your booth to get this done. They're going to have their kids doing it. Then what you do is say, I have the report here, and on the report it says email it to your client. You get the client's email right there and say, I'm at the show. I don't have a printer. I'm not going to waste ink on everybody. I mean, geez, you could do 300 in a day. What's your email address? And I'll email this to you. Now you have contact with them. You have you have their email. You email this to them. When you do, you offer them a gift certificate or a special to come on in for an actual feel and touch assessment. You're going to get clients out of this just with this little tool. Now, that's where you can learn about postureanalysis.com. It's a very handy tool for building a practice. Now, another thing that they came out with, and it's kind of cool, I did it myself, and no, I am not sharing my results, was a lean screen. They figured that if instead of doing body calipers, they are within 0.7% as accurate as a water immersion. They can do a fat analysis, a body composition test, by putting the lines on, and same principle. You do this at a health fair or whatever, or even your clients. If some of you are doing weight loss for your clients, you can do this whole division to bring clients in. That's where you learn about that and watch some of the videos. Pretty cool stuff. I got to be honest with you. So this is what we do, but you can keep it simple as just putting up just a grid sheet. It's all up to you, but I advise doing something like this. Now, how heavy is your head? You know, obviously some of us have bigger heads than others, but I'm referring to head posture. You know, the rule of thumb is anterior ear over middle shoulder is normal posture. That's your normal plumb bob. You start dropping anterior forward to past the gravity line, you can add up to 30 pounds of pressure. An inch anterior equals 10 pounds of pressure on the subocciputs all the way down to where the traps insert, about bra line, a little bit below bra line. And it can go all the way up. So just imagine that a person keeps coming in and they have major anterior head carriage. All you got to do is ask them, say, now, Bob, you know, let me ask you, do you get kind of tight between the shoulder blades, or I'm gonna poke here. You start feeling for trigger points. You're gonna find all kinds of junk in there if they have anterior head carriage. You think one visit or two visits to a therapist is gonna help? No. If they have anterior head carriage, it could be up to 6 months. This person still has normal. 3 months of care is going to be when they have normal carriage, but their normal head posture, not anterior, but their curve is starting to go away. This here, if they have anterior head carriage and a straight neck, it's up to minimal 6 months. Then it starts going reverse curve. They're starting to get into extension. They're stuck. Then it's 9 months. 12 months if they got reverse curve. Now, wouldn't it be great if every client came in between the 3 month and 1 month when symptoms first started, right? In the ideal world, but not in our world. Of course, they're going to be taking painkillers. They're going to be trying everything else. They're going to go get a trigger point injection. They're going to get an anti-inflammatory. Then they'll come to you guys, 6 months to 12 months down the road, and like, I need a massage to get this straightened out. Yes, you do, but no, it's not going to do it in 1 or 2. This is the time for corrective rehabilitation is needed. And again, depends on the patient's lifestyle. If they're working at a data entry, leaning over a desk all day long versus an assembly line position versus a teacher, all different lifestyles you have to take in factor when you're coming up with treatment plans. Could this be a marketing thing? Possible. We've sent things out, a newsletter. What's your posture number? And we talked about anterior head carriage. Are you 18, 30? Kind of like the Dr. Scholl's foot things that you see in Walmart, all that. What's your number? Well, you can do something very similar. What's your posture number? People will look and then you start getting them talking. Then you can say, come on in for a complimentary evaluation and learn your posture number and how it affects your health. Here's something you can consider doing. Client comes in, a quick posture scan, earlobe to middle of shoulder. Anterior is earlobe, obviously it's out in front. The extensors, cervicis capitis, cervicis longus, the extensors and the scalenes are in a normal position with a normal cervical curve, ear over center of shoulder. Ear anterior of the gravity line and shoulder is going to be stretching all of these guys. Do you think that can cause a headache? Subocciput, tension buildup? Yeah. And just imagine it doesn't happen equally on both sides. Normally it happens on the right side. Can anyone guess why it normally happens on the right side of the person why their levator and trap is tight on the right side versus the left, why you're going to have 60 to probably 70 to 80% more people with the right side tightness. I'll give you a second. Most of the people now are using computers, even the elderly, and that is the side that most all people use the mouse on. If your elbow is free floating in the air when you're using the mouse, it will, in about 20 minutes, start causing the levator to contract. And you start subconsciously doing this. Your upper trap and your levator will start contracting on that right side. So move the mouse pad where your elbow goes on the desk. Get a chair that has an arm where you can rest your elbow, or bring another chair over and rest your elbow on it. Okay? Or take breaks about every 15 minutes from the mouse. Okay? This we threw up here. This is just a lot of verbal vomit on here. Instead of trying to go through all of this, basically it's strain, counter, strain with cross patterns is all it is. Pelvic shifts forward and everything else. I won't go through all this. This will be in your notes so you can look at it. But just to clean it up a little bit, upper cross, lower cross. I know you guys have heard of these, and these are true in 90% of the cases. Person has bad posture, hyperkyphosis, anterior head carriage, cervical, loss of cervical curve here. You're going to be putting a lot of strain all the way up through here in the upper back. These here are going to be tight down here. Up here is going to be very weak, the flexors, okay, because the extensors are going to be tight. You're also going to have weak rhomboids, and serratus is the muscle that goes around to the abs, okay? You're going to have weak muscles there. Controversially, down here, you're going to have a hyperlordosis, okay? It's going to start tilting forward. If you have weak abdominals, what happens? The abdominal wall starts outpouching or getting the paunch stomach there. That's going to even more so cause a hyperlordosis. Then, I'm not going to get into it, but you can lead to facet syndrome, disc problems, facet arthrosis. The pelvic tilts forward. There's a lot of stuff that can be going on with this kinetic chain, okay? So crossed and upper cross, or upper cross and lower cross syndromes, very, very prominent in a lot of the clients that you're going to see. This is something you can educate them on. This is something you can write a blog on or send an email thing to them. The following traits are those with upper cross. Normally what you'll see is suboccipital pain syndromes. Right below the base of the skull, they're going to be having a lot of pain. Or they'll lay on the back, and you'll have to do like a Nimmo technique or a pressure technique to start releasing some of the trigger points. They're going to be having mouth breathing, sleep apnea. Okay, remember we said Anna was having trouble sleeping. She kept waking up, snoring. Okay, she's a mouth breather. This is some of the things that she has going on with her. Remember I mentioned TMJ, teeth clenching, face and neck pain, migraine headaches, uncoordinated gait, and loss of body balance. Another good thing you can do is have them stand up. Have them stand with their eyes open, then have them stand with their arms out and their eyes shut. See if that gets them off balance. If it does, they got a proprioceptive thing. They got probably an upper cross syndrome going on. Those are some simple checks and tests that you can do to evaluate your client. Here's an X-ray I put in. I wanted to show you guys. After a while of having straight or military neck, it will start going backwards. And this is what I mean by the backwards portion of that. The little hook right there at the top of the screen, that's where the base of the sella turcica is. That's the center of the skull, and that's where you can draw a gravity line, a plumb bob, straight down. So you can see this person's not touching, they're anterior, and they're going backwards. This person is close to normal. The bite line, the upper palate is pretty level, pretty much the same on those. So you can see the curve and no curve. This is where all our spinal nerves come out of, guys. These nerves go to a lot of vital organs. So degeneration phase, as a chiropractor or even a massage therapist, you need to be aware of this. This is normal. This normal curve, okay? They're a little anterior head carriage, but it's pretty much normal. Phase one, they're anterior and they go straight. The back of the skull is up here. So this here is the anterior. This is basically what you're looking at, the direction. After a while, we aren't made to have this type of strain on our neck for long periods. There's no cushion, no curve in here to absorb the cushion from walking or impacts. So what happens? The disc wear out. Normally, 5, 6, and 6, 7 start wearing out quicker. You can see In between the bones is a nice big disc space in the adjacent ones. This one here, it's pancaked right out, and you're starting to get spurring. These are called the osteophytes. They're starting to get spurring out here, okay? So when the disc goes down, it will go back in the canal more than likely and start hitting on some of the nerves or the cord itself, causing symptoms. Leave it and let it go on without any care, it will go reverse, and you really start getting issues. Then the adjacents start collapsing. You start getting big osteophytes. Once they fuse, they're termed syndesmophytes, phytes, and then you got bony fusion. Okay, so we don't want our clients to get to that stage. We want to try to get them when they first come in there, educate them enough, and I believe you can do that through email, through newsletters, through blogs. Okay. What about some of the nerves? I just kind of cut, this is a poster I have in my report room. Basically, the nerves that come out at different levels go to these organs, okay? These go to the eyes, the lacrimal glands, the carotids, the vessels, the lungs. T2, T3 goes to all the lungs, the heart, T4, T6 goes to the stomach. So what happens if you have a nerve that's supplying the stomach that comes out of a T5, T6 disc region? And just say that nerve is not totally impinged or crushed, but it's just enough to put some pressure on it where it still sends a signal, but it's like a light dimmer switch on the wall. It dims the signal down so you don't get proper hydrochloric acid production in the stomach. Or you could, by hitting it, you could hyperexcite it. It could turn it up. You could get over hyperchloric acid production in the stomach, and you start getting gastroesophageal regurg. You start getting heartburn symptoms. Remember Anna? She didn't eat Italian with pepperoni, but all of a sudden now she's getting heartburn syndromes. Could be because of some of this stuff going on in posture and biomechanics is starting to affect some of the nerves. So when clients come in, part of your job is to ask them about some of the other symptoms. Can you ask them about heartburn? Yeah. How about breathing? Are you getting short of breath now lately? Yeah, I used to be able to climb the stairs. I thought I was just getting old and fat. Well, it could be, Bob. You do need to lose some weight, but there could be other things involved too. Now, if there's someone in here named Bob, I apologize. I'm not picking on you. But you get the drift where I'm going with this. Lower, same thing, just different organs. Just imagine a hyperlordosis pinching in the back and the nerve that goes to the colon. That regulates peristaltic contraction, peristalsis. Say it gets slowed down. What happens? The client gets bowel obstruction. They aren't pooping enough. They go every 2 days instead of every day 2 or 3 times. What if it's down lower? Say you have some people call it a shelf butt. Say it really hooks around and going out, and you're stretching all the sacral nerves. What about if the guy is having erectile dysfunction? What if they're having bladder dysfunction? This could be all affected down in here because of the posture, and there's things we can do. So start being a little bit of a clinical Sherlock Holmes and start thinking posture in organs, not just muscle, okay? Dr. Bragg, through cadaver studies, demonstrated that neck flexion or anterior head carriage could stretch the spinal cord an extra 5 to 7 centimeters, causing tension of the meninges. Remember, the meninges is the sheath that houses the cord, and it goes all the way up the canal and covers the brain, okay? So imagine if that thing, it's like you put, now I don't wear these, but imagine if you put nylon and it's on your feet and legs and they're really tight, like pressure hose, okay? That's kind of what the meninges could be doing if you have anterior head carriage or even a scoliosis, because that will take it out, okay? What type of pressure could that cause on the cord in the brain for any of the nerves going to any of the organs? It can cause profound effects. Also, head and forward posture can have up to 30 pounds. We already know about that. Can add extra weight on the cervical spine, the upper back and neck. Pull everything out of alignment. FHP can result in loss of 30% of vital lung capacity. Remember, the lungs, first of all, comes out of the T3, T4 region, but also you're not going to be able to take a full breath because the hyoids, the the neck muscles and the upper sternal muscles will not be able to contract functioning as much. We actually did with a spirometer. It was a clinical study. We never published it, but we had about 60 of them come through where we did pre and post things. People with anterior head carriage or scoliosis, we had them breathe in a spirometer, and we found after treatment of anywhere a month to 2 months, we had them redo it again, and we followed up with x-rays so we could see changes. Everyone had an increase in the spirometer reasons. Their vital capacity in their lungs dramatically increased, anywhere from 10 to 20 to 35%. Huge results. Yeah, we never published those. It was a great in-house clinical study, but don't let it fool you. How imperative is it to have your kids sitting at a desk to have 100% oxygen intake in their lungs? I mean, it's imperative, right? Even you at a computer. Scoliosis. Again, this year, the Journal of Bodywork and Movement Therapies published reports. Massage twice a week for 8 weeks. Concluded report pain levels, sleep patterns, functional limitation all showed improvements over the course of treatment. Massage is an appropriate tool for these type of things. Okay. What happens if you have a deviation of posture? Well, if you have a scoliosis, and this I'm not going to get into that because we have a webinar that's total scoliosis. But a scoliosis is medically defined as a curve that exceeds 10 degrees. But you can have a 5-degree curve, S-curve even, 5 up top, 5 on bottom, and it's not scoliosis, so you have a posture deviation or a giant C-curve. This is where you're going to find the tight fibers and trigger points on the high sides of the curves. You're going to find the weak here, tight here with trigger points manifesting. You're also going to see it tight down here on the opposite side. You're going to have a cross pattern going on. Tight and tight, weak and weak. Okay? So you start noticing the client comes in. That's another reason why it's important to do a posture assessment. If they have a high shoulder or they bend over and you look for a rib hump, you start noticing a curve, you know where to look for trigger points automatically when they're laying on your table and how to do things and what muscles that are tight and need to be worked on. Another thing, if you have one that's really deviating off, don't forget the psoas. And this year I did one on pelvic, so I'm not going to get involved a lot in the psoas here. But don't forget the psoas. A lot of times this is the culprit of many low back problems. Connects down here to the ischial tuberosity, the trochanter, and it comes on up to the lower lumbar. So what about our diaphragm, guys? Our diaphragm attaches to the lower lumbar. Lower thoracic, the upper lumbar is our diaphragm. If your psoas is in spasm and causing a hyperlordosis, is that going to let your diaphragm contract fully? No. You're going to not get a full lung capacity? Absolutely. You're going to be missing some vital oxygen. Now, also, if one side is contracted, then you're going to get a lateral tilt with a rotation. That will stretch the opposite QL muscle, the quadratus lumborum. So you need to stretch this side, and a stretched muscle over time will start to respasm on itself and form adhesions and trigger points. You got to release all these guys when you're working with these. This is a crucial thing that you're going to be noticing when you're working with posture. The different strain, counterstrain, agonist, antagonist muscle groups, how they fit. Just a quick look. Off the surface, good-looking gal. I don't know her, but good-looking gal. Looks very fit to me. Very well put together. But if you're looking at posture, there's some things that you need to look at a little closer. I tried to take the line out because that kind of gives a little bit of a hint. But let's look in a little bit more details whenever a client comes in like this. Because if this woman just walked into your office and she walked in, you greeted her, you shook hands, and she's filling out paperwork, she sat down, you had her get up and go on your table, I would not notice unless I really watched her walk in some of the things. But if I had her stand against a backdrop or I had her stand against a grid line or I took a thing with the phone with the app, then I would notice some things. And they're very subtle, but nonetheless, it's crucial to her getting better. So one of the things right off the bat, you can see the plumb bob gravity line goes right between her eyes, right in her nose, mid-mouth to the chin. Pretty decent. But look down here in the pubis region here. She's shifted. So she has some stuff going on. Also her head, anterior to the shoulder, right? High shoulder. Look at the gap between the hands, right? There's a few things. I got them blown up. I'll show at you here. High shoulder. That should be the little dotted line, if you guys can see it going across. That's her. You can also put a thumb under the inferior border of the scapulas. You can see one's about an inch higher, an inch and a half higher than the other, okay? The other thing, like we talked about, ear should be back here over the shoulder. Hers is really forward. Do you think she's going to sustain a normal L-shaped curve in the neck with an anterior head carriage like this? No, that is probably a straight, if not, it's going on its way to a straight fast, okay? So based off this, what do we know? She has tight upper back and neck muscles, suboccipital, weak flexor muscles, because if she went forward, she would be looking straight down. So what does she have to do? She has to look where she's going. So the upper neck and suboccipital muscles have to contract, and she goes into extension and is always looking up with her head forward. That makes all these, the platysma, I mean, I'm like the hyoids, everything weak. Also crunches down on the clavicles, which portrays into the upper pecs, which inhibits lungs. Just off the bat right here. How about a head tilt? Did you guys notice this? She's tilting over to the right side. You can kind of see it here. She's coming up and she's tilting. Okay? Again, the anterior. So you got a head tilt. So what could be going on? Right side, scalenes, trap, levator could be really tight. Okay? You can also see the gap in the hands. Also, her hands are facing backwards. Rounded shoulders. Hands facing backwards. When the pec comes on around, attaches to the humerus bone on the trochanter, it's going to contract. It'll be tight. It'll rotate around. What do you see a lot of this in? Guys that are lifting weights. Now, I'm a weightlifter myself. I'm almost 230, and I'm not fat. So I lift weights, but you got to lift properly. Yeah, you want to build big, strong pec muscles, but you also want to work the back and the rear deltoids at the same time so they can counterstrain the force or the counteract the force that's going on this. Look at the clients. If the hands are facing backward, then the elbows are going to be out. They're rotating in. They're rounded shoulders in. I also see this now in a lot of the younger girls. Back when guys, again, I'm dating myself, but back when I was in the 7th, 8th, 9th grade, our girls weren't developed like they are now. Good gosh, there's some out there that are, I'm going to say Dolly Parton. For you younger guys, you should know I hope you know what Dolly is and what I'm referring to. But they're developing so much earlier. Their physical is developing, but their mental is not. So they're insecure about themselves. So what do? They put their head forward. They round their shoulders because they don't want to stick out. They don't want to be different than the rest of the class. So keep an eye on that, especially with the younger ladies, the young adolescents out there. Now, some of the theorists think it's all the GMO stuff and all the pesticides. Hey, it could be. But you also see she's developing a shelf butt. She's really starting to arch out here. Oh, well, here we go. I jumped ahead of myself. The lower cross, basically, you're going to have the weak abdominals, okay, and the glutes are going to be weak. You're going to have tight extensor muscles and tight leg muscles in the upper part, okay? They're going to be cocking it forward. They're going to be nutating, tilting the pelvic down, okay? So given kind of what we went over, what about Anna? Remember her? She has 3 to 4 headaches a week. Now, we kind of know why, just talking what we did, why she's probably having some headaches, right? Some repetitive stress syndrome, especially toward the later of the day. Left hand is numb with the first 2 fingers, goes to the thumb near the end of the workday. Probably got some tight scalenes, the anterior and medial and posterior scalenes. Definitely has anterior head carriage. So probably could have some brachial plexus entrapment syndromes, not so much from disc, but more so from muscle, which would be a peripheral entrapment. Could also have vascular with it, so it could be a toss, a thoracic outlet. We don't know. We'll cover that in just a second. Why should she be getting bad heartburn? Well, we kind of covered that's a good scenario. Why? Because if she has anterior head carriage, the T4, T5, T6, All those regions there, they can go to the stomach, cause some bad indigestion or overproduction of HCl. The upper part of that will be regulating the cardiac sphincter, which closes off the stomach, which can go back up the esophageal, could cause esophageal regurg, a number of things that the nerve supply could be diminished, okay? So make note of those. As you're treating Anna throughout your course of treatment programs, you need to be asking her, how's the heartburn doing? How's the sleeping doing? Those are all things that need to go in your notes because it all portrays to the posture in her physical, okay? Now, insomnia, we've already talked about that. You can ask her about sleeping. Anna, are you still waking up at night? You know, if she still is, she may need to go get evaluated for sleep apnea. Might have to have a CPAP machine. We don't know. That's not our job. But we can link the symptoms to posture that she's having, okay? So our assessment is we have a brachial plexus, probably not a toss, but a plexus entrapment, anterior head carriage, been under some stress at work, that we know we have a good idea why she's missing sleep, what her heartburn's coming from. We have some of these things. So what's our treatment program? What if we want to see her more than once? What do we tell her? She's in your evaluation, and you kind of took all this. She's in your evaluation room, you took all this down. What are you going to tell Anna when she only came in because a buddy recommended trying a massage? It might make her feel better. Are you just going to do that, or are you going to sit her down and educate her, not vomit all over her all the stuff you know, but educate her, say, Anna, here's what I'm finding. You repeat the objectives back to her. If you have your phone with a posture analysis on it, take a picture and show her. Picture's worth 1,000 words. Say, this here, 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 and here is what's wrong with you posture-wise. These nerves that come out of this level go right to these organs. This could tie into why you're feeling. I don't know. I'm not diagnosing, but I'm telling you what could be causing some of this. So here's what I normally do with clients that come in. We have a regular program that we put them on. Here's our program. Now, here's the program that we put, I'm going to say Anna. Hold on. I'm getting ahead of myself. So I'm going to share with you the program in just a minute. I wanted to talk about plexus entrapment because I mentioned it. Remember the brachial plexus comes on out. It's the web, right? As the radial nerve, median nerve, ulnar nerve. Remember the ulnar nerve is going to go to the last couple fingers on the hand. The radial nerve is going to be in the thumb and the two fingers, or the median nerve rather. The radial nerve will be on the back of the hand and the thumb, part of the thumb. So we have our plexus entrapment, we're talking about the neural bundle here coming under the collarbone, coming through. Then you got your pec muscles going up over. You got your scalenes that interweaves in and out. Then you got the sheath that it's housed in. So there's a lot of stuff that can happen along the way. Thoracic outlet is when you have the constellation of symptoms and you have a compression of the NV bundle, the neurovascular bundle, at the thoracic outlet, the triangle here. So you'll have the plexus, C5T1, you'll have the vein and the artery all compressed together. Then you have a thoracic outlet syndrome. And I did a whole webinar on thoracic outlet. I'm not going to go ahead and do that. That's where you can do the Ruse hostage test. You can do the pulse. Very simple things you can do to determine if it's tossed to give you an idea what you need to do or if you need to refer them. Neurogenic toss, basically a hyperextension injury, whiplash. Anna didn't come in with any injuries. She didn't fall. She wouldn't have an auto accident, but she does have repetitive stress. Well, what do you mean by that? Well, she's constantly typing. She's at a keyboard all day. She's answering the phone all day, data entering. That's a repetitive stress syndrome. Okay, so she could be over and over multiple times throughout the day, throughout the week, stressing that area. Neck trauma stretches, and neck trauma is repetitive stress. It will stretch and stress the scalene muscle fibers, okay? Swelling the muscle bellies, which will pinch the nerves, causing pain, paresthesia, numbness, and weakness. After a long period of time, you'll start getting myofascial adhesions, scar tissue. This here can lead to entrapment of various things. It can also lead to headaches, muscle spasms, a host of other things. Now, another thing to ask Anna, and I didn't put it on here, but I would, and my wife does, is how much water are you drinking? The rule of thumb is no longer 8 to 10 glasses of water a day because that's a one-size-fits-all. The rule of thumb now is half your body weight in ounces of water per day, especially if you're going to be exercising or working out in the yard. I have a lot of patients that come in, they'll have cramps, they'll have tight muscles, and I'll ask them on the water, and they're like, man, I am drinking 5 gallons of water a day. I'm in the urinal. I need to get a catheter because I'm in the urinal so much. Then my next question is, are you getting enough minerals? Because hyperhidrosis, drinking a lot of water, will actually deplete you of minerals, especially if you're sweating them out of you and peeing them out of you. So they'll say, well, what do you mean? I'll have, the potassium, the bananas, things like that. Salt. What's your salt intake? Then I'll educate them the difference between sodium and salt. What we want is increase our sodium intake. Salt has a negative chlorine ion, and I'll tell them to get the sodium, which I recommend the Himalayan pink salt. You can get it in a salt shaker. Put that on with each meal, okay? So I'm not going to get into the physiology, but there's new research showing that sodium for athletes and people that are active that sweat a lot or really hydrate can go up to a little over 2,000 milligrams a day. There's research showing some of that now. Again, sodium and salt intake, they say, is not so much the culprit. Again, don't take that from me, but do your own research. But we have been increasing our sodium intake the last couple of years, and I'm feeling a lot better because of it, to be honest with you. Again, symptoms of the toss, right through here. I won't read them all to you. Neurogenic, again, we're running out of time, so I'm going to try to go a little bit. You can also check Peck Minor syndrome. Remember, it's minor over major in a lot of the anatomy things here. You may have to do a lot of PM, Peck Minor release techniques, okay, because that will lead to all the symptoms up above. Here's a care plan that we put our Anna on. First one, we did an evaluation of client and range of motion assessment. We got our baseline. We told her we have a program. We'll have acute care, maintenance, and a wellness. Right now, we got to get her out of pain. You got to get her where she's functioning. That's going to be 6 30-minute medical massage. Medical massage, what we do is more with ART, PNF stretching, trigger point release, fascial release, whatever we deem necessary. Instead of one 30-minute or one 60-minute, we broke it up into 2 30 minutes for 3 weeks. At week 3, we did another evaluation. Did the same test that we did back then, so we kept good notes. She was doing pretty good. Then we bumped her to 2 60-minute sessions 1 time a week for 2 weeks to see if she held. If she held, she's doing good. She's doing some at-home exercises. She's working out. Great. Then we did another assessment. If she held, all things looked good. Great. Then we put her into the wellness phase, 60 minutes, 1 time a month for 6 months. Now, if you charge $60 an hour, you break this up here, it's $300. Not counting the 6 months, but to get through the phase 1, phase 2. Now, a lot of people, whenever they go into a clinic, they will pay $300. A lot of them will have a health savings card that they can even put this on. Some states require them to get a physician's order for use of the health savings card for massage. I don't know of a physician, unless they're just really out of the loop. If you present them with a 5-week care plan, say, here's what we found, here's the objective findings, here's our plan that we're going to be doing for Anna, here's the cost, we'd like you to approve this and write an order for us so we can build the health savings account. A physician is going to be really impressed if you have a care plan like this. Okay, they're probably going to be sending you clients. So come up with a care plan and have validation of why you're doing this. Then you're having pre and post checks. Okay. What we did on her is we started doing the suboccipitals first. We started releasing, doing trigger points, doing passive stretching. Then we started working down the scalene muscles, down the back of the neck. Once we got to the deep scalene, or the scalenes, they started getting to the muscle bellies on them. Then we found they were tight. We rotated the head. This is opposite what I'm going to tell you just a sec right now. We rotated the head toward the scalene that we were working on until the scalene loosened. Then, like the picture shows, we rotated the head away. Rotate the head toward the scalene you're working on until you feel release and it's becoming pliable and it's warmed. Then you rotate the head away and you put it in a semi-stretch. It's a passive stretch position, and you work the muscle bellies, the elongation of the fiber, okay? Then you did the posterior and middle scalenes. Then you start working the anterior scalenes, okay? Then you start doing some stripping. Again, watch for the 3 Gs, a grunt, a groan, or a grimace when you're doing these. Don't hurt the client. These, as you guys know, can be very, very tender. And if you're in right over here at the top of that and toward between that and the middle one, don't just start rubbing frantically to try to reduce a spasm or a trigger point. You're going to be hitting the carotid bulb. You're going to start messing with heart stuff and vascular stuff. Just do your regular muscle strips. You may have trigger points at the insertion and origins of these things. Those will be the satellite ones. The primary ones are going to be in the main muscle belly. Start working with those and do the stripping. Okay. You can also rotate the head to the opposite side of the muscle you're stripping once it's warmed up. Flip them over. Then we started doing the deep posterior muscles, the traps, the scalenes, the extensors. And again, we normally try to work the top down. Now, we also always flex the head 5 to 10 degrees. If they have a major anterior head carriage, flex it 10 to 20 degrees because they're so used to being forward, they probably have arthrosis in these joints. Being level or only 5 degrees is going to bother the heck out of them. They ain't going to relax. Flex that head way down if they have a major anterior head carriage. Okay? Again, working the kinetic chain. Once you've did the scalenes, you're going to work the PM, the pec minor, and everything else. You're going to be working top up toward the shoulder and stretching. You're also going to have the arm in rotation as you're going. Okay? Noticing the 3 G's along with trigger points. You're going to be releasing those. Work it. Remember, she's having stuff going down her hands and fingers were getting numb. Work down the kinetic chain. Work all the way down. Pay a particular attention to the bicipital neurosis or aponeurosis. Now, I know you guys some of you are going, what is that? I remember that word from the boards. Bicipital aponeurosis is the sheath that comes on over. The median nerve will be held down by scar tissue in the bicipital aponeurosis if that is strained. If the aponeurosis is tight, again, you'll start getting fibrous adhesions between that and the muscles. That can impede the median nerve, which can cause numbness in the 2 fingers and the thumb, okay, along with the radial. Once you get down a little bit more, check the pronator teres. Again, I'm not going to go into the details on all this, but work your way down. These are all in the slides. The retinaculum, the flexor retinaculum, I think we have a picture of that. The flexor retinaculum, also known as the transverse carpal ligament, once you get down here, can actually start causing issues with the median nerve. So try to release that by doing a spread apart with the carpal bones and working your way up to the extensors, working across. Don't mash deep in. You're going to hit the nerve bundle right through here. Start gentle, and as you go outward, put deeper pressure down and lateral pressure to spread apart. Okay? You can also do a cross-friction massage. Primary, secondary trigger points when you're dealing with the scalenes and the pecs, you're going to have the main ones here with referred ones anywhere along this pattern. Again, remember the fingers that we talked about? Aponeurosis, the flexors with the median nerve coming up through here. You can also have it in the palm of the hand. Any of these are where the trigger points are going to be. You need to release these trigger points before you stop work on the arm. Just because the muscles are relaxed, if you don't release the trigger points, it's going to come right back. Okay? Scalene trigger points, a little bit different pattern. They can go in the front, but a lot of them are going to be in the back, right along the border of the medial border of the scapula, down to the rear delt, to the medial inside head of the tricep. Okay, all the way down to the elbow to the flexors on the inside here. Those can be anywhere as the scalene is going to manifest, all along here. These will be the primaries. These are going to be the secondary, or satellites are called. What about braces? You can look for posture braces. Just do a Google search. There's a ton of companies making these. These are little cheap ones that are effective. They can go under clothes, especially in wintertime. You'll never know the client's wearing them. They go from $5 up to $50. Depends on how elaborate you want. These here are $5 to $7. And you can order them, sell them for $15, $20 to the clients, whatever you want to do, or give them at cost plus shipping. Doesn't matter to me. But I would recommend selling with a 33 to 40% markup, because that is your products and goods division of your practice. I talked about that in one of my business webinars. So you need to develop an ancillary goods in your practice. You can stock these. Okay? K-tape, you can stock kinesio tape. There's a ton. If you go on YouTube and type in kinesio or K-tape for posture, you will have a ton of videos showing this. You can even give the client an email link and sell them some tape, and they can do it. Okay, there's a ton of ways to do this. I don't want to get involved with teaching this. I did a course on this, but that's not applicable for this one right here. But this is the basic patterns for anterior head carriage, levator scapula syndrome, especially with the mouse muscle for the computer. Typical cross pattern, typical age pattern for rounded shoulders and posture. Okay. Scapula problems, wing scapula, this type of pattern works great. Anterior head carriage, this works great. We also do towels. We'll have them roll up a bath towel or a wedge. We order these wedges from Scrip Hesco. Has these. You can order online. They're like $7. We sell them for $15 to our clients. What we have, and my wife does these too. Because if you're trying to work with posture anterior head carriage, you want to get the curve back. So we'll have them lay on the back. 5 minutes, 20 minutes, 5 minutes first night, 10 minutes, 15, 20 minutes, all the way each night. No longer than 20 minutes. Week 1 to 2, you do it every night. And you can do the same thing with the towel if you don't want to order the wedge. I like the wedge. It's a little more professional and abrupt. But that's the pattern that we normally have them do. Okay, and I'll let you read through that. I always get asked, what is a good pillow? What's a good mattress? First of all, the pillow. I personally have seen too many patients that have 2 pillows and they always have neck problems. I recommend 1 pillow if you can tolerate it. The ones that have the contoured, the problem is if you lay on your back, it's okay, but as soon as you turn on your side, then you're getting a bend in the side of your neck. You're getting a lateral curve in your neck. So I tell them just get a flat pillow and, whatever they can sleep on. If someone's been used to this and they're sleeping on it, great. Mattress, this is way too soft. This I feel is too hard. You want something that's firm, that you can have the indentations go down a little bit, but still maintain pliability in the mattress, okay? I think this is a little too soft because I don't sleep my shoulder right under me like that. I don't know too many people do. It's normally rounded a little bit. That's hard to give a straight answer. It's a medium bed for everybody because some people, one of the best ones that I have seen, they're expensive, is the number bed. Because if you're out working all day in the yard, planting flowers or planting the garden, lifting bricks and blocks, chopping wood, you go to bed that night, you're not going to want a hard one. You're going to want something soft because you're going to be sore, your muscles are going to ache. Same thing, if you sit at a desk all day, the next day, you're going to be kind of stiff and hunched over. You're going to want something that's not soft. You're going to want something that's going to support the posture. You're going to want a firm one. A number bed can be dialed to hard or soft each night depending on your activities of the day. So, in my opinion, if you can afford it, the number bed would be the way to go. Otherwise, rule of thumb, I kind of like a medium or a firm or a firm with a pillow top can also do the trick. That's my opinion. What about our kids? Backpacks? You could do a whole blog, a whole article on this. This is going back to school time, guys. What a great newsletter to send out. Use these pictures if you want. No heavier than 10 to 15% of the body weight, okay? That's kind of hard to do with some of the teachers now. They're wanting the kids to carry 80 pounds of books from class to class. What ends up happening is the bag drops down because of the weight. It pulls the kid backwards, so he has to lean forward just to keep it up so he can walk correctly. Same thing here with the girl, just so she can walk correctly, major anterior head carriage. I also know it's kind of cool, or it was when I was in school, to sling it. You're the hip guy if you slung it over your shoulder. Looking back, that's not so cool biomechanically because you're going to cause a giant C-curve and a lot of weight on one side, pelvic shifting, anterior pelvic tilt on one, and rotation, okay? This is kind of a good thing to use for patient education. I like the ones that have a strap and have wide padded shoulders. And the kids need to do them both with a lighter weight like this one shows. What a great topic if you can talk to a school board and do an educational class to teachers. or parents at the school. Do it voluntarily and do a posture assessment. Take a picture with your phone with the new app on it and have a heavy backpack and a light backpack and show demonstrations. They would love you. What you want to talk about getting clients? What a great marketing thing, guys. Keep that in mind. You guys that have been on my webinars, you know this is one of my favorite slides. It does everything. Don't forget the big picture. Flat feet, pes planus will roll inward. You have a lot of stuff that causes this anterior pelvic tilt, drop in the shoulder, rotation. All these things can cause posture, so don't just look up here. Also look, the person may need new shoes, they may need an arch support. Could be a number of things. I'm not going to go into that because we did a whole webinar on foot and ankle conditions. You can lead the bunions and just a ton of stuff. Again, with that thing, overpronation or pes planus will cause internal tib fib rotation. The knee bows inward, knock-kneed, creates a wedge on the inside, stretching the ligaments, pain. You also rotate around. If you rotate the leg around, you're going to stretch the piriformis muscle. The sciatic nerve branches under or sometimes in between the piriformis muscle. That can cause a peripheral entrapment, causing sciatic symptoms all the way down just because of some of the posture deviations. Again, your pelvic on the side of the flat foot will tilt forward. When that happens, we get hyperlordosis, kyphosis by defunct anterior head carriage. We talked about the importance of all those. The fascial train patterns with an anterior pelvic tilt with a flat foot will be the side of involvement will be on the side of the flat foot for the lower. Cross pattern will be all the fascia on the opposite. Cross pattern will be up here and out to the deltoid region. You'll also notice a gap. The picture doesn't show up. You'll also notice whenever they have this, the gap between the hand and the hip at total relax will be wider on this side than it will on this side. I think that's the end, and I held you guys a little bit over. I apologize. We're about 10 minutes past. Questions, shoot me an email, info@clublmt.com. Notes, I'm going to go ahead and start things converting and uploading now while we go grab a bite to eat. When I get back, it should be done, hopefully. The internet gods will be nice. I will get them out to you as soon as we get back. Certificates and tests, I'll have a test that'll be with this that I'll send. If you want the CE, take the little mini quiz, email me back the answers, and within a few days, my staff will get you your certificate. Just make sure you put how you want your name and what credentials. All right, guys, gals, it's always fun doing these. I look forward to clinic retirement where I can do more of these, and actually where we can start doing live seminars where we have stage presentations, and I call you guys up out of the audience onto the stage and be some of my practice models. So with that being said, if you guys are ever at one of my live shows, come up to me and let me meet you if you're on my webinars. I look forward to meeting you guys. So it's a small world. Anyways, you guys take care. Have a blessed rest of the week. Take these, use these, build your practice, and go help some people. All right, guys, take care and God bless.